The girl's frightened out her life. She's, this is only 2 weeks ago. She rang her GP. GP can't give her any liver function tests, and she's got to go to Bangor Hospital, but she won't see anybody for 40 weeks. So I am suggesting to her, and I would like you either to endorse or tell me I'm talking rubbish. I'm happy with either. I'm suggesting she goes back to her GP. She gets a hold of our liver function. Somebody has got those numbers. If they don't, to ask to have them done again, and to be sent, given all the research that's coming up as well, David, to be sent on to her nearest liver unit, which would be the Queen Elizabeth in Birmingham. But I'd like you to give me your advice and wisdom on this one, please, David.
Okay, so just the antibodies again. It was weak positive AMA, and then GP210 was positive.
And M23E.
Yep. Okay, and then GP210.
Yes.
Okay. Okay, so and presumably, I'm just assuming that those tests were done because she was feeling so tired. That would make sense.
Yeah, she's got all the symptoms: itching, tiredness.
Okay, right. Okay, so and that's good, because we would encourage. I mean, this is something that we make a point of all the time: is that PBC. For people with itch and fatigue, PBC is a common cause of those things, and so therefore you should think of PBC in the general population. So people should think of PBC when you get those symptoms. So it's one of the oddities. We've seen this with chronic fatigue syndrome, that for a long time they didn't screen people for liver disease when looking for causes of fatigue. Now they do. There is a sort of danger that long COVID will come along and people will become transfixed by that. And what will happen is people will miss something that's there and potentially treatable, that's important. So so in that sense, that's good. I think the idea that you can't make a diagnosis for 40 weeks is just nonsense of the first.
Well, they told her she has got it, sorry, but she won't be seen or offered medication for 40 weeks. Sorry, David.
Right. Well, that's a nonsense of the first order. So I think we've been very clear. So the reason why that's important is that there are two stages to the treatment of PBC. The first of which is to start people on UDCA and then to let that settle in and see what happens. And actually, in terms of symptoms and in terms of other treatments, you need to treat with Urso first. And so that's the thing that you do right off, and then the rest will all follow in time. Now 40 weeks is a bit long to see how somebody responds to Urso, but it's unacceptably long to start Urso. And what they should be doing is starting you on UDCA. There is no contraindication in anybody. It's as simple as that. We've been very, very clear with the guidelines that we've written, and all the messaging is that Urso universally is the message in PBC. We also did some guidance with COVID. We did some guidance at the request of various different clinicians. So a group of us got together and came up with some guidance about PBC in the era of COVID. So Intercept helped pull this group together, although it wasn't anything to do with their drugs. It was because of this sense that people weren't getting, the correct treatment with it all. And the question that we were answering is, if everything is going to be slowed down, what can you do? What should you do kind of automatically, and what should you wait for? And one bit of that guidance is very clear, which is that the use of two drugs is what we would call first aid for PBC. So you start those without thinking about it. Well, you're thinking about it, but you know what I mean. And then what you do is review how you've got on. And those two drugs are UDCA for the disease itself and cholestyramine or Questran for itch. Both of them are very safe. They're universally used. They're first-line treatments. They do not require a hospital appointment to start them. Those are prescribable by any GP. They're very simple and very straightforward. And so you need to be started on UDCA. It's as simple as that. Now, the question is, will then be, question then will be, how well does that work and where do you go from that? But you won't know that until you treat it. And so therefore you need to go. Even if the liver blood tests were really not great, you'd still want to start with UDCA and see where you go. With regard to the itch, actually, there's a long debate about whether itch is improved by UDCA. The sort of trials and textbooks say it isn't. A lot of people think it is. And so I would just do this. I would do this, up front. We operate in our clinic here we see people usually within 2 weeks of them being referred, always within 4 weeks, and we continue with that, throughout COVID. And so we don't do this in our region because we would always like to see people and explain what you're trying to do, because actually that helps people, down the line. But where there are real problems, it seems a shame. If people are, if people want to know, well, it's a busy time for the health service, blah, 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 blah. There is published evidence from the UK PBC that the delay in starting UDCA is associated with a worse response to that UDCA. So the messaging we're giving out now is not only do you treat everybody, but treat everybody immediately. If somebody was had the blood test that suggested PBC, came to our clinic, they would leave that first clinic visit with a prescription for UDCA, because you simply don't know what's going to happen afterwards. So you really need to start that, sort it all out, see what is left after that, and then take it from there.
Right, so in practical sense, she's got to get the Urso from her GP.
Yes.
And what do you feel about her being asked to go up to Birmingham? Because, she can't wait 40 weeks. And she wants to be part of all the research programs as well. And that's a key to getting her in there.
Yeah. So, I get that. I think there's what you do now and what you do down the line.
Yeah.
So what you do now, irrespective of anything else, is to start on UDCA, because the first thing they would do in Birmingham or Liverpool is the other centre. And it all depends on the referral patterns, with it being Wales. So in a sense, all they would do is start on UDCA. They do exactly what I've just said. So what you don't want to do is to have the clock ticking until you start UDCA, because then you have the clock tick again on the UDCA. That's why it's first aid for PBC. Right. After that, I think, there is we would see anybody in our region, irrespective of anything else. So if people, people want to come and see us, then we're happy to do that. I think in terms of do you need to, I think that slightly depends on what the problems are that are left after UDCA treatment. And genuinely, you can't predict that until you do it. In terms of research, there are those things that take place everywhere. So the UK PVC platform kind of exists in Bangor like it does everywhere else. It's in all UK hospitals. The more advanced research around trials and things tends to be in quite specialised centres. Although Liverpool is very good at that, and there are good people.
Yes, they are. Yeah.
So that may be more practical, but it is to do with referral patterns. And obviously, whether any trials or anything are appropriate, we would always encourage people to at least find out about trials. They're not there for everybody. All the drugs that we explore in trials in PBC are safe. That absolutely is the first priority, and a number of them are reused drugs from other settings. And there's been enormous progress, and that wouldn't have happened without people taking part in trials. But they're not for everybody. You have to have a few more visits to the hospital, and if you live a distance away, that's a problem. But please do all find out about it. Now, whether any trials are appropriate would obviously depend on what the blood test did after the UDCA. But I think the very clear guidance, the UK treatment guidelines, are very, very clear indeed. The national guidelines for PBC is that you should be started on UDCA immediately, and the add-on guidance given in the time of COVID is that people should not wait to be seen in a hospital. They should be started on UDCA by their GP. So beyond that in terms of treatment of the disease, but they should be treated on UDCA.
Excellent. So if that lady, any questions, give me a wee ring, but
Yeah.
you heard it here. She does say at the end, I've researched on your website and also the definitive guide for patients with PVC by Professor David Jones, would you believe? This has been a great read where my brain is working.
No, seriously, I mean, I think, you know, we've talked, I mean, we joke about the book, but it was written for a reason, which is to help people fight their way through the system. And actually, you know, one of the chapters does go into how you should make sure that you get what you want and need. And I think that's really important. And I think being very clear, and I think I like everybody else, you know, really worry about some of the issues that people have had getting, you know, through the sort of treatment pathways. And I am very concerned that COVID is starting to be used as an excuse for a variety of different things, and nothing is gained at all by waiting with treatment. I think we go into, you know, for those of you who know the history of PBC, there was a long debate about UDCA and how effective it was and who you should get it, and it's really important to realize in 2021 that entire argument is over. We now understand why it arose, but everybody with PBC should get UDCA, full stop. If you can't take it, because a small number of people get side effects, usually to do with the gut. And one of the questions that somebody came forward with is, do you get wind with UDCA? That's an easy one, yes. It's because it's a bile acid. So a small number of people really can't take it. A larger number of people, you need to kind of adjust it a little bit and get used to it. But you really need to try to take it. It's kind of it's the beginnings of everything we do in PBC. So diagnosis, Urso, and then we go off in lots of different directions depending on what else you need to do. But it's what's left after Urso treatment started that dictates that.
So it's a long walk. It's a long walk.
Did you notice I answered 2 questions there? One of which
I did actually. I'm going to good marks. I've got a wee comment. I was on live on Facebook yesterday. By the way, people in from Mexico and all places. Wednesday afternoon, you were talking about Thursday and Professor Jones, and I made the following comment, which is sent by mail. I felt emotional as I wrote this. Professor Jones's book was published at a timely moment in my life, and without your and his comments through the time of COVID, I would have been in a very difficult situation. The knowledge I gained from the Thursday afternoons helped me make decisions for myself. I think you're all marvellous for the way you battle on. Thank you.
Well, you know, that's lovely, isn't it? And I own it. You know, my plea to everybody is own it. Own the problem, own the solution.
Yeah, and we'll help you down the line.
Yes.
Right, what's your finish time today, David?
Exactly 1:15.
Right.
Okay. That it was going to be 1:15. But own the problem, own the solution, and if you don't be fobbed off.
Yeah.
If you don't like what people are saying to you and you're being fobbed off, push back at it. And I think, and I say this all the time, and I'm not just saying this, the foundation are fantastic at supporting and empowering people to do that, and you deserve it. You know, you'll get all manner of, oh, it doesn't matter, oh, it's not important, oh, all of that, don't you know there are people with other problems, oh, COVID, all of that. Your health, the basics, the art with PBC, and we teach all our junior doctors, is simple things done well every time in every person. And, you know, so many of the problems that arise, people haven't done simple things, you know, done well every time in every person.
Yeah. Excellent. Right, and hello from Bernadette and Ayrshire. Right, I'm going to hammer through these because they're coming in thick and fast. Following, it's on the screen, a lip biopsy, I've been diagnosed with Sjogren's. Many of us have, only nice people get it, like Pbc. Any advice you don't have medications to avoid? Well, that's pretty straightforward as well, isn't it, David?
Any medications to avoid?
To avoid, you know, the ibuprofens and the anti-inflammatory.
Yeah. Okay. So Sjogren's, I mean, it's somewhere in between a nuisance to a problem. It's not quite the same as standalone Sjogren's. So Sjogren's is a condition that people can get without PBC. Then it's often associated with, you know, joint problems, a little bit like rheumatoid arthritis, but it seems a little bit different. So it's a first cousin, if you like, of the standalone Sjogren's. It typically doesn't have a lot of the complications that standalone Sjogren's does. So it's usually milder than that, but can be a real irritation. there are some medications that will make it worse. So antidepressants can make it worse. Not drugs like sertraline, those more modern ones, but some of the older ones like tricyclic antidepressants, so amitriptyline and things, they can dry your mouth up naturally. And some what are called anticholinergics, so some nausea drugs can do it. So if you've got a drug that has made it worse, just be aware of that. And the great thing is a lot of these things are now available online. So, in the old days, it's very difficult to get information about that, but Dr. Google is very good. So if you can go in, Wikipedia, strangely enough, is actually pretty good at this. If you want to see if a drug you're taking causes side effects, then Wikipedia is actually usually pretty good about it. So just search on it. But the classic ones are things like some of the anticholinesterase, often used for irritable bowel and things like that. And then in particular, and nausea sometimes, and then tricyclic antidepressants. So if you have got Sjogren's, particularly with the mouth, important thing is mouth hygiene. So keep your teeth really clean. As I will say before Collette does, avoid mouthwash. It's poisonous, literally poisonous. So it's not as good. Water, mouth hygiene, and brush your teeth. And then the one that people always forget about is swallowing. So pour saliva. Saliva is there to do two things. One is to keep your mouth sort of clean and disinfected, and the other is to help food go down. And people often don't think of that. So if you are getting food stuck a little bit, slightly smaller, mouthfuls, and watch out for really dry things like dry beef or dry chicken, and just take lots of little sips of water. And my tip is always use fizzy water rather than still water. It for some reason, I'm sure if there's a physicist here they can explain, it does help lubricate better. So the main thing is avoid some drugs that make it worse. Avoid getting food stuck, and keep your mouth nice and clean. People often ask about some of the sprays and things as treatments for it. I have to say I'm not a big fan of any of those, because people tell me there's no go-to treatment. So those promise a lot, but don't quite work as you might hope they would do. Dry eyes, similar things. You can feel gritty, sometimes feel like you've got something stuck in the eye, can make it prone to infection. So yes, okay.
These are very good. They're relatively new. They're very good.
So it's not, you don't want Optrex and things like that. Those are hypermellocyte. They've got some starch in them, which keeps the fluid in there. With those sorts of eye drops, you can't take too much of them. They are just literally water plus something to keep it in the eye. And again, topical treatments as you need them. And then if it's a real problem, if you're having to use that 6 or 8 times a day, then there is an incredibly neat treatment where they pop a little plug in the drain that runs out of the eye. And it sounds, awful, and it isn't. They just fit little plugs. They last about 2 to 3 months before they drop out. But the nurses in the clinic then can refit them, and it's literally a 2-minute job. And actually, it's one of those things that people have come back to me and said they've been enormously effective. And if you put those in somebody who hasn't got Sjogren's, you'd be literally crying all day long, because we all produce a lot of tears. But if your tear production is very low, it's well worth thinking about. And we have a brilliant service from our ophthalmologist eye doctors here, who do that for people, and it's a game changer. So that's something to watch out for. Not if you're using eye drops once or twice a day. I think it's a bit much for that, but if it's really bad, think about it and see.
I'm smiling. For a month I had 1 plug in and 1 plug out, and I had a wet eye for a month. It was fantastic. It was lovely. Right, I'm going to march on. Now this lady, I think you've got most of this medical information, but in summary, she's had PBC since 1995, early 40s. Everything's been fine, tickety-boo. She's had recent tests, and there's signs of portal hypertension and various things. She's been put on medication. She's had no face-to-face with anyone who can answer questions or explain the situation. She lives on her own.
Yeah.
And this lady is quite distressed. Now, I have made sure she lives at her nearest unit is Addenbrooke's. I've said to her, given the quite substantial change, that she should ask immediately to be referred to Addenbrooke's. Is there anything you've seen the whole of the email? I'm just summarising.
Yeah.
Was there anything you'd like to add to this, David?
No, I think, you know, and clearly, you know, in the catchment area of Addenbrooke's, you know, there is an excellent PBC doctor, George Mells. Everyone knows George. He's a really good PBC doctor. So where you have got that, you know, Pallet Trivedi in Birmingham, in that part of the country, and in London, you know, it's pretty well covered for it. So I think it's easy. It's crazy not to. And, you know, I think it clearly hasn't behaved exactly as you'd want it to. And so I think it's very wise in order to get that just kind of looked at. So I think that would be sensible. And certainly, again, we would never have a problem ever seeing anybody, you know, referred in from the region, largely because there's a lot of reassuring you can do, but also want to know what's going on with it. So I think I would agree with that. First thing to say, so the first thing to say is, if somebody's been labelled as having cirrhosis, the first question is it really there? And this is what I would think in the clinic. Is that really the case? And one of the traps just to be aware of is that just an ordinary ultrasound or a CT scan can overestimate the presence of cirrhosis, okay? So radiologists sometimes interpret the name PBC, and sometimes in PBC you can get a bit of an irregular liver anyway, and so sometimes they put 2 and 2 together, make 5. So that's the first thing. Over the years, if I had £1 for everybody I've been sent up with you know, query cirrhosis with PBC who doesn't have cirrhosis. Now, I don't think that's what's happening here, because you've got the varices. So you know, varices are varices. Okay, so the first question is it cirrhosis? And I suspect it is here. So the next thing to say is not to worry about that. That on its own doesn't mean anything. It means, however, you need to have a heightened sense of awareness. So cirrhosis itself doesn't change the outcome in PBC, strange as it seems, but it means you have to just be absolutely tight about your treatment. So actually, in all the scores that all the people use over all the years, actually having cirrhosis doesn't add to people's risk. It's if there are problems with it. So the next thing to do is just make sure that everything is managed. So the first thing is make sure the PBC is controlled as well as you can, because cirrhosis, if the disease is well controlled, causes far fewer problems. So it's even more important to have Urso, and if the Urso isn't as effective as you would like, to get the right dose right, to think about second line therapy. So that's really important. Tighten up on everything. And then, as the consultants will have said, to make sure that you screen for complications and things. Everyone worries about varicel bleeding. So where varices bleed, everyone worries about that. We have not seen a patient with PBC have a varicel bleed in Newcastle for years. And that's because the medical treatment that you're on is very good at doing that. It's a preventative treatment. And that's what's being used. But it sounded like it's not been explained, and it kind of needed to.
No, I think that's the problem here, David. This lady's been left with a report. She's not a doctor.
No. So the only thing that's missing from the information I saw is what the blood tests look like now, because that would dictate whether you need another treatment on top. But I can just say, having seen it all, that all looks fine. They're doing the right things, but they're not explaining it to you, which means they've not done it right. But the drugs are there to control, you know, address sort of the complications and things. So you do need to just have attention to detail where cirrhosis is there. One of the things people say, but I've been on Urso for all these years while I've developed cirrhosis. Actually, PBC over lots of years, there is an element of how bad it is, but there is also an element of how long people have had it. And grumbling disease, it can happen. So it isn't that anything's gone wrong with that. It's just perhaps a sign that it's been there for a long period of time. And I think where we are today is we are very much thinking about how to get total control of it. I think in the past, getting it better than it was the goal of treatment. And probably that allowed it to grumble away in a number of people. And I think where we are heading towards now is getting a much better control over it. So sometimes just having had it for a long time is the main risk factor, and that then doesn't tend to create problems. So I think it just needs to have that sort of bespoke extra look. Does everybody need to come to a specialist centre? No, not at all. But there are certain groups of people, like those who haven't really responded to Urso, or people with bad symptoms, or people, for me, who've got cirrhosis. But the most important thing is, do not worry about that word. That's just indicates that we go down this particular part of what we do. And one of the things that the guidelines did really very well, the new guidelines, they split PBC into three things, three pillars. One is treat the disease, Urso plus or minus another drug to control the disease is pillar one. Pillar two is see whether there is cirrhosis there, and if so, screen and manage. And pillar three is to treat the symptoms. And what we do is educate people to go through each of those, but it is not sequential. It doesn't mean that it goes from one to the other. It means that you can have, everyone needs the disease managing, but thereafter you do whatever you need to do. So think of the first one first, the second one set, and then the third one.
Okay, great. We're doing quick fire now, okay?
Okay.
This is the problem with brainy doctors. They know too much. So this is about the shingles vaccination. Apparently PBC being an autoimmune disease, this lady cannot have the usual vaccination, but must have Zostafax or Shingrix. I hope this makes sense. My doctor would not commit herself to my having it before I cleared it with any of my consultants. It's impossible to speak to anybody. Do you have any view on that?
I've got to be honest. I've never been asked that question before. And all I can say is we offer no guidance as to avoiding any vaccine for people with PBC. Okay.
Interesting.
So we don't offer that guidance, largely because PBC is not that autoimmune a condition, and the evidence about there being problems isn't nearly as clear cut as people think it is. So it's one of those things that a lot of people worry about, but in practice doesn't seem to cause problems. And I don't know enough about those individual vaccines, but generally speaking, this idea that you need to avoid vaccines if you've got autoimmune disease is a bit of an urban myth that has arisen. It's been propelled a little bit by COVID. I think if you are immunosuppressed, which most people with PBC are not, that's people on tacrolimus and MMF and drugs like that after a liver transplant. It's a slightly different matter, but most people, the only issue is the vaccines might not be so effective. So I think in this era, I wouldn't particularly flag it as a concern.
Okay, great. So this one, diagnosed PBC in 2009, increased difficulty walking any distance and had more frequent days of fatigue. Whoever this gentleman is, I would like you to phone me and we can have a chat. He's under the care of Chester Hospital. His scan shows a deterioration to liver cirrhosis, so he's in HCC watch. Fine. I'm considering the possibility of a motor scooter and wonder what the above count towards my getting VAT accept. Well, we don't give that kind of advice in terms of VAT exemptions. But what I did want to say to this gentleman, I'm sure David would agree with this, that PBC should not really stop you walking, and there's a case here for you going back. There is a major change. Any kind of change needs a complete review because we do get other things. Would you endorse that? Yeah. So a couple of thoughts on that. The first is absolutely. So PBC, it is common to get fatigue. There can be a muscle component to that. So people can feel like, quotes like they've run a half marathon. People need to sit down in order to carry on. So, it's very common for people to say, when I went around the shopping centre, I had to, remember which shops had a seat outside because that pacing themselves. Mm-hmm. But as I always say to people, the funny thing about the fatigue is that
often people really struggle to feel like they can exercise. But if the fire alarm went off and it was a genuine fire, you'd be out as fast as anybody else. So there isn't a fundamental problem with walking. It's just more of a struggle than it ought to be. That's where the typical PVC thing is. And if it's more than that, then as Collette says, it just needs to be thought about. Because there is always a danger people put 2 and 2 together and make 5. So one of the traps that we see all the time is people assume that things are to do with PVC when they're not. PVC can cause some odd and unusual and unpredictable things, but it also doesn't stop you getting other conditions. So I think that if it's beyond just feeling a bit worn out and wanting to rest, it needs a look again to make sure there isn't some other cause for it. With regard to VAT and things, I'm not an accountant. What I would say is that a lot of these things, in a sense, require recognition that this is a real problem. And Collette, actually, of all people, I mean, because of work she's done, knows this inside out. But what I would say is that in terms of personal payment in PIPs and things like that, PBC fatigue is a recognised problem, though sometimes you have to struggle to have it recognised. Sometimes you have to go through several iterations of that. But in terms of disability, this certainly can be recognised as a disabling condition for blue badges and things like that. But sometimes people are not as sympathetic and helpful as they want, and some of the companies that they've outsourced the assessments to. But absolutely, is this recognisable as a chronic physical problem that leads to limitations? Yes, it can. Don't be detracted, but don't be deterred if people say no automatically. What that means for VAT exemption is above my pay grade.
Well, as an accountant, somebody sat in the tribunal for 12 years. Please do give me a call. I'm really, Chris is sending me question after question. Chris, get your fingers off the keyboard, boy. So this lady diagnosed, she had sepsis during an emergency C-section. So she's asking about diet and what's too much alcohol to prevent cirrhosis. But I'm going to say to you very quickly, because I am happy for you to phone in and we are going to fire through these questions. Diet, stick to good healthy food, keep away from processed, keep away from sugars. Go into our website, there's a lot there about diet. And alcohol, I'll let David, but it's important you're on medication, it's important you're on Urso and you're being monitored. Call me at the office. Your comment on alcohol is, David, what?
So just go back to diet. You will see a lot of stuff on the internet that's out of date about protein restriction and fluid and all of those things.
True, good.
The protein restriction thing is way out of date. So there is no specific dietary advice that you need to, things you need to avoid or things you need to eat, and the capacity for diet to improve or cause PVC to get worse is limited. Okay, so just be aware of that. The one thing to be cautious of is that people can sometimes get fat intolerant and so can struggle with fatty food, get gripey pains or diarrhea, and that's because of the effects of PBC on absorbing fat. So just be aware of that. If you do pay the price eating fatty stuff, just watch the fat in the diet. Alcohol, I mean, I'm going to rush headlong into saying you haven't got an alcohol problem to drink more than your hepatologist, but I won't, because that would be predictable and trivial. The truth is that many or most PVC patients don't drink any alcohol, and that's their choice. Okay. If I'm asked somebody in the clinic about alcohol, my advice is that you're going to have to live with this, right? One of the things that we talk about is how to live your life with it, and therefore it's important to live life and not do things because of a sort of arbitrary concern. And I think it's one of the things that we always talk about the junior doctors is if you're going to give people advice that's really going to change their life, be really certain that it's right. Don't just give throwaway, don't do this, don't do that, and then stop thinking about it. Because if people take it at face value, they're not going to they're not going to be. And I saw a few years ago somebody who the greatest sadness in her life was not having children, and she hadn't had children because a doctor once had said you can't have children with PBC. She had stage 1 PBC. It is appalling. And so actually there is nothing that somebody with early PBC shouldn't do compared to anybody in society, not anything. Alcohol isn't anything to do with PBC. It doesn't make it worse. It is not drinking alcohol doesn't make it better. However, anybody with a liver abnormality can be less good at tolerating alcohol. So I think, you know, a glass of wine once a week, or, you know, at a wedding or something like that is fine. And it, you know, there is no, hepatologists do not tell people to avoid alcohol unless they have alcohol liver disease. Okay. So our advice is everything in moderation, that it's part of a normal and healthy life. You do not need to avoid it. Many patients don't drink it, that's fine. But I think if that is a way of, you know, enjoying life within moderation, I think that's just fine. But other people would say things that are different, but there is no evidence at all that you need to do anything other than what I've just said. Okay.
Jane's asking on screen, our appointment in June was cancelled because of COVID. She's going back in November, meeting was in August, and now have an appointment in November. Do I get new? Yes, get more blood tests. Why not? Get them up to date.
Yes.
So I'm jumping here. I've got 3. So I'm really going to hammer it there quick. Is amitriptyline okay to take with PBC diagnosis? 10 to 20 milligrams max. Somebody's in early stage PBC.
Yes.
Okay, brilliant.
Okay. But it is a tricyclic antidepressant, so it can sometimes make dry eyes, dry mouth worse. Okay.
And so I'm reading what Chris is, I'm jumping around. Chris is sending me, hi there, is there any info available as to whether my LFT should be done as a fasting test or regular? Fasting or not? I don't think it matters, does it, David?
Doesn't matter.
Okay, great. Do you know what? See, this business is getting old, David. You have to do this. Change your glasses. I see so many comments of people talking about whether they should take certain supplements, and about 90% of the time someone says, right, so they're talking about should they be taking supplements or not. You will not get any Western medical doctor telling you to take supplements because they've been untried. Any comment, David?
Other than I don't have to problems with glasses because I'm not old. Just that.
I'll catch you later.
Okay, supplements. Okay, so Colette's absolutely right. Is that there's no trial evidence about, you know, any of these things. I think there are 2 things to think about. One is vitamins, in a sense, vitamins for potential deficiencies, and then the other is, if you like, sort of therapeutic supplements in various different forms. So with regard to vitamins, most people eating a completely normal diet will not have any vitamin problems. However, you know, the fat malabsorption, you know, if you are struggling to absorb fat, can affect, you know, some vitamin levels. And the one to watch out for is vitamin D, which has become very topical with COVID. Yeah. And we've stopped measuring people's vitamin D levels at PBC because everyone's vitamin D levels are low. And that's not to do with PBC, that's to do with society. We slap factor 50 sunblock on. Sorry, Collette, for people in Scotland, the sun is a big yellow thing.
Oh, yeah. Thanks so much.
You know, shines through the rain.
We had sun yesterday.
But it'll all be better when you're independent. So vitamin D, actually, right, everyone pretty much can benefit from vitamin D supplements in society. It's we've just basically wrapped ourselves up so that we don't get vitamin D. So I think it's reasonable to take a good generic vitamin supplement because it will cover anything that you are missing out on. And if you're going to do that, and this is just one you can get from a supermarket, I would also get one that has the minerals as well, so minerals and vitamins. And this just makes sure that you are not light on any of the kind of vitamins and minerals that can have a sort of unusual absorption pattern. So that's not medical advice, that's a common sense thing. It's a reasonable thing to do. In terms of sort of therapeutic supplements, there's some evidence about things, but much less. So a lot of people talk about things like St. John's wort and and so on and so forth. And I think none of those are harmful. Okay, none of those are harmful. None of those have any evidence to suggest that they are beneficial. However, most of them haven't been looked at. And I think it's not unreasonable to try those. I don't think there are any problems with that. And if it helps you, it helps you. It's just there's no kind of more broadly based evidence. The one there's an exception.
Come back. All is forgiven. Are you there?
Oh, this is a coenzyme Q10 is a vitamin. We actually did 2 trials on it. One of them showed benefit, one didn't. Therein lies the issue. And I think if there's anyone that has more evidence than anything else, it has some trial evidence that it works, and a lot of people take it. So, and that can sometimes be useful for energy. So I think what you do is you read the packet always. I think try things. And if it helps, it helps. If it doesn't help, it doesn't. But none of them should cause any particular problems. What I wouldn't do is spend a large amount of money on them. And what you will often find is, for many of these, since coenzyme Q10 is a classic example, you can buy a really expensive one or you could buy a really cheap one, and it's exactly the same. So there's a lot of marketing uplift on a lot of these things. And what the difference is usually the outlandish claims. So I wouldn't spend a large amount of money on those things, but a good general multivitamin is not an unreasonable thing to do.
Okay, now there's a belter of a question. I remember asking you this question 25 years ago. It's coming.
Oh, yeah, I've set somebody with my son comments about Scotland. It's a lovely place.
Something up on the screen, is it?
Yes, I said my son comments were not nice.
Well, it's
I feel bad now.
You can you ask about white? And yes, yeah, I will in a minute. Yes, I will do that. Bernadette, I see your question there. Bernadette's a bit of a star. She's in a wheelchair. We'll come back to that. Bernadette, I'm really trying to get all these in. Is weight gain an issue with Urso, and if so, why?
Yes, is the short answer. It's actually scientifically proven. So there's research showing that it's the case from Keith Lindor, who's one of the genuine stars and nicest people in PBC. So he did a study years ago showing that there's an average gain of 2 to 3 kilos when people start Urso. Why? The reason is that when you have PBC, you're not as good as absorbing fat from your diet. It's to do with the way in which the bile works. PBC can act a little bit like a diet. You can sort of diet without realizing it. So a lot of people may have come across a drug called Orlistat, which was available in Vogue a few years ago, that helped people lose weight. It works in pretty much the same way as PBC, having PBC works. So unfortunately, one of the side effects of PBC can be to lose a little bit of weight. Back in the old days, we used to see people with real problems with that. When you take Urso, it reverses that. So one of the effects it has is it makes it easier for you to absorb your food more normally. And so Urso doesn't cause you to gain weight. It's not a side effect of the drug. It's a side effect of the normalization that comes with Urso. So I'm afraid it's part of the effect of Urso. So just be aware of it and be, just be sort of, cautious about it and watch what you eat. Would I ever not use Urso in somebody because of potential for weight gain? Absolutely not. It's far more important to get the management of PBC correct, but just be aware of it.
Mm-hmm. Next question. I've read that magnesium is good for lowering the GTT. Is there any evidence? It's a yes, no one really, isn't it? Magnesium.
Not that I'm aware of.
No, okay. So I'm going back to the screen now. Are bulging veins part of PBC? Jane, I'm going to hand that back to you. What bulge do you mean? Varicose veins? Can you come back and tell us a bit more about that? Because it's a very broad question and we are hammered on time here. Having trouble sleeping, any ideas? I'm absolutely desperate. Jane, we have lots of things on our website. I'm happy to speak with you on the phone. David, I mean, I'm not sure it's a medical thing. Is there anything you can comment on sleep?
It's often abnormal with PBC, and it's a factor in how people feel, because disordered sleep often then contributes to fatigue and brain fog. And sleep is a very complicated area, and one of the things that stops people sleeping is worrying about sleeping, because it's a bit like, you know, everybody here will be very familiar with going to bed early because you've got a flight or a train the next morning that's early, and lying there thinking, I need to get to sleep, I need to get to sleep. And the one thing you can't do is sleep. So thinking about sleep and worrying about sleep actually makes sleep problems worse. So there's a whole complex interrelationship with it. PBC patients are less likely to sleep at night and more likely to sleep during the day. So I always talk about sleep being black and white normally. So black is asleep at night, white is awake during the day. In PBC, it's kind of dark grey and light grey, and that's part of the disease. And it is something that we look at very carefully where people have got fatigue or brain fog, because it is modifiable. Now, it gets very complicated. We could have a whole session on this. Maybe we should actually have a whole session on fatigue and sleep. Yeah. And it is, interestingly, an area of a lot of research, a lot of therapy development. The first thing to do, however, is simple things. So if people are struggling to sleep, watch your tea and coffee intake in the evening, or Red Bull or Coca-Cola. It's one of the most bizarre things about British behaviour. People who can't get to sleep go downstairs and have a cup of tea. And that is the surefire way of guaranteeing you won't go to sleep, because there's more caffeine in tea than there is in coffee, and it keeps people awake. So avoid anything. I don't drink coffee after lunchtime, because if I do, it stops me getting to sleep. So watch out for that. Watch for stimulant drugs and things, you know, anything that keeps you awake in the evening. So just think about sleep. And then the other main question, and it's a horrible question, but do people snore? Because the whole path for how you think about sleep starts with whether people snore or not. If people snore, it's often an airway problem, and that has one particular approach to treatment. And if people don't snore, it's much more likely the PVC-related sleep. And for those of you, in the old days, we used to do complex sleep studies and bring people into sleep labs. But something simple like a Fitbit or an iPhone, they have got quite extraordinary functions to measure sleep. I mean, the technology is amazing. So a Fitbit nowadays, a simple Fitbit, which costs 30 or 40 pounds, can actually measure sleep patterns really accurately. And so if you are worried about sleep and wondering what the patterns are, it's something that's worth looking at. So it's where technology is really useful. And actually, there are specialist sleep clinics that can look at sleep disorders. And I think just a little bit of information gathered. So it is complicated, but it is part of PVC, and it is a treatable aspect of what we do.
Yeah, but Jane, happy if you give me a wee ring at the office and then give you a bit.
Genuinely, Fitbits and heart rate monitors and things like that, the technology to help you look after your body health is extraordinary compared to how it was 5 or 10 years ago. It's really cheap. The information is great. Looking up to a smartphone, you can find out enormous things. And the key thing to do, if you're going to do that, is just watch patterns, right? Just watch patterns. Get a sense of how your body works, what your heart rate does and different things, you know, how you're sleeping, how you're feeling, and try and spot patterns. And it's part of the owning. We've
got a message from somebody in Northern Maine. She's saying basically she had PBC 9 years. She's facing bowel cancer for the second time in 20 years. She's in surgery next week, and she was saying she's too busy concentrating on the PBC. Anyway, she's saying, peace be with you all. You both look great. Look, we wish you all the very, very best with your surgery. But do get back in touch and let us know how you're doing. And I very much appreciate your comments. The lady...
Can I just add to, I would echo all of those comments. Absolutely. The first is, absolutely, PBC is not everything. It is something, and therefore take everything else as seriously as PBC. That's really important. And then the other is, one of the things we encounter is often about treatments, often about drugs or operations, where people say, you can't have that operation because you've got PBC. 9 times out of 10, 99 times out of 100, that's nonsense. So make sure, and if in doubt, that's where we can provide advice and things like that. The caveat is if people have got cirrhosis and varices, that can make things more complicated. But if you've got early PBC, well-treated PBC, there is no surgery that you can't have. that you need to have. And so it's really important. And it sounds, if you're having surgery next week, fantastic, they're going ahead with that. But if people ever say you can't have an operation because of your PBC, always question why specifically. There is no blanket reason you can't. I wouldn't have cosmetic surgery with PBC. Anything that is important for quality of life or length of life, there is intrinsically no reason whatsoever why PBC gets in the way of it.
Excellent, good. I'm going to flip back. The very first question is about the lady who was asked to wait 40 weeks or told to be waiting 40 weeks after being diagnosed. She did make a comment to my phone, and I beg your pardon, I forgot to mention this. Now, it's very significant. Her poo is white.
Okay. So
that's why I said liver unit.
Yeah. Okay. So where you are, so stool color can change. Stool color can change. White stools can occur if bile flow is not correct. Okay, because the pigment in bile, the bilirubin pigment in bile, goes out into your bowel, and it gets altered, and that's what makes poo the color it normally is. And if bile is not getting into the bowel, then it can go. Worried about that, and it isn't as common as you think it is, and it would be very unusual if somebody wasn't jaundiced, if they weren't yellow with it. But and that is extremely unusual in PBC, so to be jaundiced to that degree. So I agree completely that if you have somebody who's got a stool change like that, particularly if they're jaundiced, what you need most of all is an ultrasound scan done, pretty much immediately. And from that, you then need to have whatever other imaging that you need. So that suggests, a real, if that's the case, it suggests the potential for a bile flow problem, and that is a slightly different category. And again, if I saw somebody with what we call an obstructive jaundice, so they were jaundiced and they had pale stools and they were AMA positive, I normally would think that there's two things going on there. That is not a combination of things you would typically see with PBC. And I think, remember what I said is that don't have 2 and 2 put together and make 5. A gallstone blocking the bile duct, something like that, but that needs working up. And the first port of call is an ultrasound, and then after that we typically do what's called a magnetic resonance scan to look into that. So therefore I think that is important, and that's not because it's query PBC. It's because it's one of those things that needs flagging up.
Attention. And my sincere apologies. I'm feeling quite pressurised with all the questions, so I humbly apologise to that lovely lady for missing that out. Sorry to you as well, David. It is important. Very quickly, hello, I'm from South Wales. I'm 77 years old. And she's had bleeding under the skin in her forearms for a long time, which got worse last year when she was anemic. However, after eye meds, the diet, it's all resolved, but the bleeding has got worse. She read in Professor's book that skin can get thinner with PBC. So is there anything I can do about the problem? It's most unsightly when I've been active, such as dressmaking, sorting laundry, making beds, and now I have the spots moving up to the top of my arms. Other than wearing long-sleeved gloves or long sleeves, is there anything else I can do, please?
Okay, so the first thing to look at is whether there is a problem with clotting or not. Okay, and in medicine you have what are called decision trees. So you have a killer first question that then decides where you go with it. So the first question, any situation where you've got bruising or bleeding under the skin or anything like that, is blood clotting normally? And the way to work that out is with blood tests. So there are 2 bits to blood clotting. One is the proteins that are produced by the liver that stop blood from that help blood to clot. These are the proteins that are blocked by drugs like warfarin and heparin. If you want to stop stop people from having blood clots, so they're treatments we give for, thrombosis and things like that. So they can cause bruising. So, and that's measurable with a single blood test. The blood test that a lot of people have for their warfarin observation, we do those all the time. Mm. The other one is platelets. Those are the little cells that clump together to form the clot. And those, can drop in various different situations. So the first question, if somebody's got more bleeding like this, is their clotting normal, or is it not? 9 times out of 10 in this situation, clotting is normal. It's unusual for it to be a clotting problem. And what it usually is just skin thinning. So the blood vessels become a little bit vulnerable with thinning of the skin and tissues becoming a little bit lax. Now that is an anno domini thing. It's made worse a little bit by steroids if people have taken steroids, but it also can happen probably more than it does in other people with PBC because of the kind of nutritional things that go with it. One of the things that can contribute to it is low vitamin C levels. So, ironically, given what we've talked about before, it's one of the things that it's just worth making sure, because you need various different factors, vitamins and things to help clot normally. So it's one of the reasons to take a good multivitamin. Although again, that's pretty small print stuff. So just check the blood clotting is normal. When the doctor next see you, mention it. Obviously, if you're on steroids and things, that's a different matter. Just think about taking a multivitamin. But other than that, it is, I'm afraid, one of those things, and there isn't anything easily you can do with it. And as I said, in most people, there doesn't turn out to be any particular cause for it. It's not a worry. It's not associated. Bleeding under the skin, bruising like that is not usually a problem. It's deep bleeding. People, if people have a bleed into a muscle, that's where you can lose quite a lot of volume of blood. With the anemia, just need to be sure that that's not connected. And so you do need your blood count checking and any abnormalities in that kind of looked into. So it's one of those things where it could just be one of those things, but it needs checking. And the trouble with it, we're in danger of kind of saying the same thing with lots of questions. Check it out with a blood test. This is the sort of thing that there's not been happening in COVID. I mean, we check out all these things all the time automatically. It's what we do. And it's where this is the sort of thing that it's become much more difficult. And the last time I looked, you can't really work these things out in a telephone consultation. And I think that's where the face-to-face stuff we're missing.
Yeah.
And I think but it's very important not to be fobbed off.
Yeah.
Blood tests like that, simple, it makes you, it helps you decide where to go next with it.
Yeah. Referred to the QE in March, AMA positive, raised ALT, AST, PBC mentioned, but no treatment yet. Blood results and scan normal, now waiting conclusion of MRI scan and repeat autoimmune screen. So I think the question is about why you have not, no treatment has been mentioned. I think, you need to ask whoever's looking after you at the Queen Elizabeth, because clearly tests are not complete. Was that fair enough, David?
Yeah, I mean, if it's an ALT or an AST elevation rather than alkaline phosphatase elevation, then it is a sort of atypical pattern. I have to say my practice is to treat everybody with any liver blood test abnormality with PBC with Urso, because it's cheap, it's well tolerated, and it's the baseline for everything. So our practice is simply to give it to everybody. I mean, not put it in the water, but give it to everybody with any liver blood test abnormality. I think you can sometimes overthink these things.
Yeah, I think so.
But it's difficult without seeing the full test set in front.
Sure.
The question I always ask is why not? There was a great Professor Neuberger, who everyone here will know. He once, I think, came up with the very best quote about Urso. It was in the middle of these arguments I alluded to about whether it works or whether it didn't. And he wrote a wonderful piece about, everyone knows James, and he's very philosophical. And he wrote this long piece about the evidence that it is effective and the evidence it isn't effective and the different viewpoints. And then he said, so what are we to make of this? Well, at the end of the day, if I had PBC and I was 50, would I take Urso? Yes. Why not? And it's a simple thing. And I think you can sometimes overcomplicate these things.
That's right. Early PBC, blood's only slightly raised. Can I have yellow fever jab?
My caveat about vaccines is yellow fever. Hence the laugh. Is that yellow fever vaccine is a very old-fashioned vaccine, and it's quite a dirty vaccine. And of all of the cautions about, in my experience, now the official answer is there's no answer, but it is yellow fever vaccination is the one thing that I have seen trigger disease and make it worse of all of the things. And I haven't been asked about yellow fever for a long time. Yeah. But I've seen it, 2 or 3 people, more autoimmune hepatitis than PBC. But I've certainly seen people with yellow fever vaccine that's played a bit of havoc with their disease. The thing about yellow fever is that most people, the risks of getting yellow fever are minuscule in most settings. It's very much out of date. And most people took yellow fever vaccination because of vaccination certificates being necessary to go to certain countries. And that has largely disappeared. So I suspect the number of people having it is vanishingly small these days. So I would maybe flip it around and say how certain is somebody that they need yellow fever vaccine? And if they go into a country where the risk of yellow fever is so high that the yellow fever vaccine is important, if I had liver disease, probably wouldn't go there. And that may not be the answer you want to hear, because yellow fever is a genuinely awful, awful disease. And I think it's most tropical diseases are a manageable thing. But if there's a real risk of yellow fever, then I wouldn't. Remember the old travel clinics will give you very specific advice. Remember, though, within countries, the guidance differs. And I always quote Turkey as the example. So if you go to a beach resort in Turkey, the infectious disease risk is just the same as the south of France or Italy. It's European. If you go 30 miles inland, it's the same as, Pakistan or India. So it is very much, and the old advice in the Empire days is always live near the coast. It's actually correct. So many of the problems are in internal parts of countries where often sanitation isn't as good. The only caveat to that is sometimes coastal areas and stagnant water and sort of lagoons and things can sometimes be the problem. But generally speaking, if you're going off and staying in the Four Seasons somewhere, then typically, and you're not going to go trekking in the interior, the risks are pretty similar to the UK. So yellow fever, I would always, that one just does have a little bit of question mark, but it would all depend on where you're going, why you're having it. But most people having these vaccines are to have a piece of paper, and it's not as necessary as people sometimes think it is.
Right, okay. I had COVID last month. Should I get the vaccination or not? Yes. Yes?
Yes.
Yes, okay. Coming to Scotland in 2 weeks, it's safe to use insect repellent. Yes, thank you. There will be no insects here in 2 months' time.
Yes, insect repellent is fine. Although the idea that Scotland has any midges, I'm pretty... I've had my fingers burnt with the sun comment, so I'm going to say Scotland is nice throughout the year, and just think of the midges as your friends.
I'm quite sure the person who made the comment realised we're having a bit of fun, and if you can't take a bit of a jog at these sessions, then don't visit them. Right, so this lady, very quickly, she feels that she has white coat syndrome.
Yeah.
Bilirubin 25-26, ALT 26, albumin 38. The alcohol's down from 801 to 282. Her blood pressure, she's worried about toxins. Her blood pressure reading was 150/80 with an average of 139/70. They've given her medication is by soft bisoprolol, 2.5 milligrams, can it have a negative effect on the liver?
Right, okay, a couple of things there. So the first case is, so for those people who aren't familiar, white coat hypertension is when your blood pressure goes to the roof when you go to the clinic to have it measured, okay? And I have terrible white coat hypertension. And
do you?
You'll find that bizarre, because I know I have insight, I know I do, but it's physiological. So I actually do have high blood pressure, but the measurements done in the GPs are meaningless for me, because they are always totally unrepresentative. So for those people, it's a real thing. It's not people getting emotional or something. You know, I'm totally rational about it, but I always know my blood pressure goes up when my blood pressure is being measured. The way around it, again, this is where technology is very helpful. You go on to, Amazon, brackets, other shops are available. You can buy Boots, you can buy really accurate blood pressure monitors really cheaply, 20 quid. And they're incredibly accurate, just as accurate as the ones they use in the clinic. And the point about those is you can sit at home watching the TV and then just do your blood pressure. And what you find is that it's the true measurement. So when I have my blood pressure checked, I just show them the ones that I do. Now, my wife is a critical care consultant and works in intensive care. I am not allowed to get away with a high blood pressure, but she accepts that, it's white coat hypertension. So if you want to keep your blood pressure checked, get yourself a blood pressure monitor, cheap as chips. They're really accurate.
She's a vegan lady. She has a low sodium and a really sugar diet.
The really important thing with blood pressure is that it's easy to go the other way. So if you do have white coat hypertension, they can keep loading you up with more and more antihypertensives. And one of the commonest reasons why people get fatigue with PBC is too low a blood pressure. And the commonest reason they have too low a blood pressure is because they're antihypertensives. So it is linked, and you need to make sure that you know your true. Now, blood pressure control is really important to stop people getting strokes and heart disease. It's really, really important. But it's also really important not to go too far the other way. So it is very important. I suggest to lots of people in the clinic get a blood pressure monitor and just check it regularly at home, own your blood pressure, and therefore own the treatment.
Yeah, that's
none of the blood pressure, to answer the actual question, none of the blood pressure treatments that would normally be used have any impact on the liver. Okay, so they're all fine with regard to that. Generally speaking, a beta blocker like a bisoprolol, those will make fatigue worse in people. So just be aware of that. And so a combination of tablets that doesn't have a beta blocker sometimes can be better if people have fatigue. There are about 3 or 4 different types, and so generally we would tend to stay away from them. But it's important to get your blood pressure right, not low. People tend to think there are 2 sorts of blood pressure. There is good blood pressure, there is high blood pressure. There are 3 sorts: good, high, and low. So I always say to people, really low blood pressure isn't good if you get really low blood pressure walking across the road in front of a bus, okay, and you keel over. So you do need to get it right and not overshoot.
Great. My question is, can Bbc intensify after gallbladder removal?
So there's a big association with PBC and gallstones. We used to see it in the old days a lot. It was the commonest route to diagnosing PBC, and it's because bile flow is abnormal in PBC. So PBC predisposes to gallstones, okay? So they are linked like that. Gallstone surgery shouldn't make PBC worse, okay? Sometimes operations can make it a little bit worse, but you would expect that. That's a bit like somebody jumping into a swimming pool. They go down for a little bit and then they come back up. So you would expect that to come back to normal if it's got worse with the operation. If people's blood tests are abnormal and ongoing after gallbladder surgery, worth getting an ultrasound scan just to make sure that everything is as it should be after that. So normally it shouldn't. If it's a short-term blip, yes. If it isn't, then just watch out for it. Now, just make sure. In the old days, Urso was used to dissolve gallstones to stop people having gallstone surgery. It's not very good for that. but sometimes people think it's used for that. So just, I mean, I know it's obvious, but make sure somebody hasn't stropped the Urso because the doctors thought it was there for their gallstones. So just continue with the Urso as you did, but it wouldn't normally make it worse. So if it's a little while afterwards and it's a sort of significant worsening, get an ultrasound done.
Okay, so I'm going to have to be picky and choosy here. Bernadette, you raised a brilliant question about sport. I think we haven't got time to answer that today, but I think we need to really, I would like to do a bit of a session on sport and PBC and paraplegia, etc. So Bernadette, my darling, if you bear with us, let's do something better on it because we're limited to time.
I'm not going to make any cheap jokes. Happy to do that, really important thing. Might be worth getting one of our physio colleagues along to talk about that. I will make, if I'm involved in it, I will make no comments about Scottish sport and Scottish goalkeepers. None.
Bernadette, I'll kill you. This girl's a winner. She's a dream. And Melissa, yours is a big question. I've got you on the list. I think if we've got time, we'll do it. Raynaud's phenomenon, is it common in PBC?
Raynaud's? Yes, very.
Okay, there you are. Somebody's saying, what were the eye drops that you showed? They are called Hyco, Hyco, San. Okay, and they're brilliant. They're very good.
And sorry, just to follow up on a comment in the chat about the bisoprolol thing, okay, and the fact that it can make you feel worse. When so it's not a secret. I had very high blood pressure, and it's now under control, and I'm But at one stage, they put me on a beta blocker, okay? And I couldn't walk around the supermarket without sitting down. I remember at one stage having to sit on the floor in order to be able to finish going around the supermarket. It felt like literally that unplugged my batteries.
Oh, dear.
It was awful. And I moved away from a beta blocker and it went away. And that gave me more insight into how I think PBC patients feel than anything. But I literally had to plan what I could do. And people would stop and say, are you okay? I had to sit down on the floor because I couldn't walk another step. And that was beta blockers.
Gee, so David, that's awful. And now there's a very, very good question here. Do you recommend COVID vaccines and which one do you think are best for PBC? Just before David answers that, I want you to go to last Thursday, the last 10 minutes with James Newberger. Absolutely adamant about people getting the vaccine, David. And he spoke about all the various countries in the world and how this may have an effect, if you don't, on potential transplantation. But this lady is saying, do you recommend it? Which the foundation would do. Is there a particular, which one do you think is best? I don't.
I without question, okay? So without question, I mean, you know, I am an overweight middle-aged man and I got the vaccine as soon as I possibly could because it's overweight middle-aged men who die of COVID, okay? So I've been through this and looked at all of this. Are PBC patients particularly at risk from COVID? No. Are the vaccines safe? Yes, actually incredibly so. And we do have now pretty long-term information with them. And all I would say, without egging this, is that I have managed COVID patients and it is not a place you want to go. And the one thing that everybody is very clear is that what the vaccine has done is turn what is like a pretty horrible bad cold into a really horrible life-threatening illness in a significant number of people. And you'll hear endless talk about, does it stop transmission? Doesn't it stop transmission? Will kids still be able to school? Blah, 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 blah. That's not where its effect is. Its effect is the progression of the disease from a relatively mild one that doesn't need you to go to hospital to one that puts you in an intensive care unit. And that is all the difference in the world. And so that's why vaccines make a difference. So would I have, to anybody on this call, almost without exception, the age range of PBC, knowing what I know, would I have a vaccine? Yes, beyond question. Okay. Which one to have? I think they're all safe. There is, the clotting risk is very low indeed, although I think it's there. I think if somebody has a history of clots in their family, and there are several people who've had them, probably the Pfizer vaccine of the common ones has a lower risk. Both of that and the AstraZeneca vaccine, by the way, have a lower risk of causing of clots than COVID does, so it's never a reason to do it.
Question answered.
Which one would I take? Whichever I was offered, given a free choice. And I suspect what you'll find is most people are now being offered the Pfizer one, or one of the more recent, equivalents of that. But please, please, please have a vaccine. I have seen a number of people die of COVID. You do not want to go there.
Okay. Somebody said that they heard you doing a OCA trial. I understood you're recruiting people. She lives in London. Is she a potential? Yes.
Yes,
right.
we're looking at this. So we are looking at this, and we are. So if you drop us an email, we'll and I think what we're very happy to do is to explain to people, what it involves, and leave it up to people whether they want to be involved or not. So when we did trials before, we got told in no uncertain terms, don't us make decisions about what's a reasonable distance and what isn't. It is what it is in terms of the distance. So yes, we've Erin Wetton, who is going to do one of these calls at some point. You want to listen to Aaron. He's the loveliest guy you'll come across. He's much nicer than me. And he's our fellow running the trial, and he's an absolute joy and wants to do one of these talks, but he'll get in touch and explain the kind of the whys and wherefores.
Look at the time. How are you fixed? Have you got to go?
5 more minutes.
Okay, right. You're amazing. Is coating on the tongue related to PBC or the medication?
Coating of the tongue, it's difficult. Lots and lots of different causes. Sometimes it can be caused by the mouth issues with Sjogren. So good mouth hygiene, but avoid the mouthwash. Sometimes odd sensations in the mouth can be caused by deficiency of zinc and things. It's one of the reasons why when I said take a multivitamin, take minerals with it. So zinc and copper and things like that. It's one of those things where cover all the bases and make sure you really clean your mouth, keep it clean, sip water regularly, particularly after you've eaten. And again, a good reason for a multivitamin. Remember, there is no evidence that vitamins work, but there is no evidence that vitamins don't work. And in fact, there's never been a trial of vitamins. And everyone gets very strung out on clinical trials. And of course, with a new drug like obeticholic acid or something like that, of course you have to have trials because of side effects and effects and things like that. But there are some things in life where you just can't and never will do a trial, and so we will literally never know. And so you have to work out on people like me and you all talking together. You've got to look at the risk and the benefit from it. So the absence of a trial showing it works isn't the same as a trial showing that it doesn't work. It doesn't, people treat them the same. And just remember, people with type 1 diabetes who take insulin, there is no single trial that shows that insulin is effective in type 1 diabetes, nor do I think we'll do a placebo-controlled trial where we give some people a dummy and some people insulin, but we still think it works. And that's the limitation. Strangely, I always say to people, just to show I understand, I'm sensitive to cultural differences between the UK and I said between the UK and Scotland. That's bad, isn't it? I've fallen.
No, we're part of the UK. That's us. We're British.
The Scottish legal system has not proven. So there's guilty, not guilty, and not proven. And not proven is really useful thing to think about. Vitamins in PBC are neither guilty nor not guilty. They are not proven.
Okay. Would bariatric surgery be okay with type 2 PBC?
Type 2 PBC?
Stage 2 PBC, sorry. Yeah, that's talking about diabetes. So I'm not seeing very well with these glasses.
Yeah, bariatric surgery. I mean, yes.
I'm still here.
Weird. Yes. So that sort of surgery, the risk is with varices and advanced liver disease. So it's about cirrhosis. Okay. So abdominal surgery is always higher risk if you've got cirrhosis, or higher risk if you've got cirrhosis. So we're asked all the time from bariatric surgeons about whether a particular patient is safe for it, and the answer is almost always yes. What I would say is I can't give that specific advice. So it does need somebody who's seen your scans and your blood test just to check with that. But at stage 2, no problem at all.
100%. Can you be AMA positive but not have PBC?
Yes, you can. We published papers on this a long time ago. So there is a group of people who get AMA and never get any PBC, for sure. And there is a small group of people who get AMA and the AMA goes away again. Sometimes infectious diseases can trigger it. So there was a comment about a bad infection and developing PBC afterwards. Yes, is the answer. Bad infections, for a variety of technical reasons, can trigger the AMA process. So over the years, I've seen a number of people who've had a bad infection, develop AMA, the AMA goes away. Although I always say to people, do not expect it to go away. Once AMA is there, it typically stays for life. But if it does go away, it doesn't mean it wasn't there originally, it was. Where people develop AMA but don't have abnormal liver function tests, what we do know for sure is that they almost never go on to develop bad PBC. So we gave up following people after about 25 years. And nobody who presented first with AMA and normal liver blood tests went on to develop cirrhosis, to develop bad PBC, to need transplant after 25 years. So sometimes it can be part of a very slow burning PBC. So if people are AMA positive and have normal liver blood tests with us, what we do is we continue to follow them up because we're a research clinic, but it can be done by a GP or by another doctor as long as somebody does it. And the moment, or if the blood tests ever become abnormal, the alkaline phosphatase, the ALT, we would start people on Urso at that point. And that's all we would do.
Okay, my blood tests always come back showing inflammation. Is this a PBC thing? You'll need to be a bit more specific about what the inflammation is. So if you could tell us a bit more for next time round.
Yeah.
I had my first oh gosh, I can't read this. But I had my first appointment. It was my GI post-June diagnosis. What's important to ask? Have been on Urso for 3 months. So I've had my first in-person appointment with the GI.
Yeah. Okay.
Post-June diagnosis, right?
Yeah. Okay. So absolutely, you need to go there, and a bit of advice is just write your questions down, because particularly if they're not an empathetic consultant, you can sometimes feel rushed. So, and also take somebody with you. Okay. So take somebody with you, and then just have your questions, and assume you're going to get 2 or 3 questions and use them wisely. Okay. So for example, a lot of people come along and say, why did I get PBC? Now that's a really interesting question. And if anybody's interested, there's a good book on that.
It's in the bit of facts, half a page.
Joking part. Don't ask that. That's what sessions like this are for, and the educational programs we run. And it's a really good question, but it isn't going to change what happens to you there and then. So the questions you need to know. So assuming diagnosis made a few months ago, and you are on Urso, okay? The 2 questions you need to ask are: 1, am I heading towards being an Urso responder or not? Okay, and that dictates what you do next. Now, 3 months is a bit early. Normally it's a year, but a lot of people have responded by 3 months if they're going to. So question 1, am I an Urso responder or not? And what's the direction of travel? Okay. And the second is, have I got cirrhosis or not? Okay. Statistically, you are likely not to have, just based on the numbers, not knowing anything of the details, because the vast majority of PBC patients don't. But have I got cirrhosis or not? Now, they won't correctly do a biopsy to find that, absolutely not. But they should do one of the other things. Now, Fibrous Scan is a very important test. This is a variant of ultrasound that measures how the liver reflects. So that's available in lots of clinics. So it's good to have a Fibrous Scan if that's available. If not, interpreting some of the blood tests can help with that. So if your platelet count, we mentioned it before, is normal, that suggests almost certainly you haven't got cirrhosis. Sometimes there are some things on an ultrasound, like how big the spleen is, can help. So have I got cirrhosis? And if the answer is no, what are you basing that on if you haven't had a liver biopsy, which you won't have done? So those are the two questions which dictate what you're going to do. If you've got symptoms, okay, fatigue or itch, then I would use the third question to say, what are you going to do about it? Okay. Because you don't want to, and ultimately you will know whether you've got the symptoms or not. So, and those three things, the treatment, am I an Urso responder, have I got cirrhosis, and what are you going to do about my symptoms, are the three pillars I mentioned of PBC management. And that's those are the questions that clue them into you know, answering the things that you want to have answered, and they should answer those questions. And if they're not prepared to, ask to go to a clinic where they will answer those questions.
100%, yeah. Or phone us. David, we've done all the questions. What Chris has been sending me now is lots of thanks and roses and kisses and all sorts of things. Thank you so much. We're going way over time now, everybody. Sadly, we have nobody for next Thursday or the Thursday after. I'm really sorry. There's various things on. We have nobody. We're still trying to get somebody to come in. Watch our website. We'll try and announce it. In the meantime, David, you've been an absolute star. You're on your time.
Sorry, just to say is that I'm very happy to step in if at all possible, but I'm unfortunately at big meetings both those Thursdays. I did look if I could move them, but I can't.
No, thank you. There does seem to be a lot of big liver.
Although even this wonderful audience will tire of me eventually, I think.
I would doubt that. But Melissa and Bernadette, and you made a good point. Maybe we could try and get a physio or somebody, David. If you have a physio in mind, let us know. But Melissa and Bernadette, well, we will answer those questions. David, thank you so much. I'm going to let you go. Alan, you just saying goodbye to everybody.
I'll echo that. I just said thank you to everybody who attended today, and another wonderful session, you know, from you both. Absolutely fantastic, very interesting, very informative, and well, let's look forward to the next one whenever it is.
David, thank you.
Thank you very much.